I'm a lung cancer doctor here at Wake Forest, and I'm really excited to introduce our set of experts today. We'll be speaking on various topics, not only speaking about treatment of lung cancer, but really going on to the support that's given to patients who undergo cancer treatment, especially for lung cancer, and specifically looking at some novel programs that we have looking at precision medicine. So with that being said, let's go ahead and get started. I want to introduce a little bit of background to lung cancer. It's actually quite fitting that we are here today in this location. For those who don't know, this used to be a tobacco factory. And it's almost symbolic in the change of the tide, where this is now a new space. I was here when this was an empty warehouse. It was pretty worn down. There was asbestos all over the place, and they came in here. They spent a lot of money, and now it's a great place for education. Our medical school's right next door, so this is quite fitting. And I think this is a major accomplishment, and because of organizations like the Lung Cancer Initiative, it was done so much in such a small period of time. We continue to support it. They continue to support patients, and I think ultimately this is why we're here today, to support those patients. So thanks for coming to the Power Up. Lung cancer, it remains a major problem. And let's see if I can get the slides moving here. It remains a major problem. It's how big is the problem? Well, the majority of non-small cell lung cancer, unfortunately, continues to present with advanced incurable disease. And this is even in the face of lung cancer screening. We're doing better, but the reality is this is what we see. And, although it doesn't get much press, it is the most common cause of cancer mortality with a grim 5-year survival rate. And if you think about the survival rate and how it stacks up to all the other malignancies that we often hear about, by far, it exceeds those put together. So if you think about lung cancer as a global health burden, it's one of the most common cancers and leading causes of cancer deaths. In 2016, there's your estimates, over 200,000. And then in terms of deaths, about 158,000. This was 2016 data. And the survival rate is still not as good as it should be, or about 18% overall. But there's a lot more promise. There are five new agents received FDA approval since 2015, 2016, which is pretty amazing. So when we start thinking about local regionally, it remains a major health burden. And here's we highlight that compared to the state norm, our catchment area, which does cross state borders, shows incidence of over 17%. And when you look at mortality, it matches that elevated rate. And a lot of people ask, why are we seeing this problem here? If you just look at the state map and the tobacco companies that are here, you can see that this is the epicenter for big tobacco. So this obviously has had a cultural influence here in the region, if not the state. So certainly that plays a huge role. And this is just looking at the elevated lung cancer mortality above the U.S. rate, which is quite high. Essentially, every county in our catchment area shows elevated mortality. Again, it's because that incidence is also quite high. So here at Wake Forest Baptist Medical Center, we really focus on this problem. We have a multidisciplinary program dedicated to cutting-edge care for our cancer patients, and the whole goal is to really improve their outcomes and support them as best as we can. So with that being said, let me go ahead and stop there and introduce our first speaker, who is Carl Gray. Now, Carl Gray is an associate professor of gerontology and geriatric medicine. He's the director of our palliative care program here at Wake Forest. And really, since his arrival, things have been pretty good. Before him, this was tough. And I want to say that he certainly has improved the lives of the patients we serve. but more importantly, he's been a great colleague and collaborator. So with that being said, please welcome Dr. Gray.
Thanks for those kind words. Now, do I change by hitting down?
Yep.
All right. So yes, I'm really excited to be here to talk to you all today. And what I want to know is that palliative care is a complementary rather than competing treatment, a competing approach to lung treatment. And you might not know that the most innovative palliative care research is really rooted in collaborating with oncology for patients that have lung cancer. That's where the most important research started and where the most important research continues to be. So, where did it all start? And I guess I should just say that, so what is palliative care? Palliative care is it's a medical treatment provided by an interdisciplinary team to those with serious illness to help improve their quality of life. That's at its most basic form what palliative care is. And we also help the caregiver or the care partner of the patient. So in 2010, a very important paper came out in the New England Journal of Medicine. And this was published by Dr. Temmel at Mass General. And what she found is that there were two arms of the study. There was standard oncology care for those with advanced non-small cell lung cancer. And then there was another arm that they got the same care, but they also had early palliative care in the clinic setting. And what she found was that the people that had early palliative care, they're also getting chemotherapy, but the people that had palliative care had better quality of life. They had less depression, less anxiety. And the thing that surprised everyone was that they actually lived longer. They lived about 2.5 to 3 months longer than those that just had standard oncology care. Now, that was surprising because palliative care has often been thought of or has a stigma of being hospice or being end-of-life care. So what Dr. Temmel really focused on was she said, the most important thing here is that they live better. That's what's most important. And the other thing that's really important is that they didn't die sooner. But she couldn't describe why they lived longer. She really wasn't sure. And there was a lot of discussion before this paper came out for why that was the case, and they really weren't sure why. So this came out about 2 months ago, and this is in JAMA Oncology. And this is another paper looking at over 20,000, actually it's about 23,000 patients who have lung cancer in the VA setting. And you've got two graphs here, but I want you to really focus on this one. So it's a retrospective study, which means they look back at all their data, and they were looking at survival. They wanted to look at survival in those that had palliative care and those that didn't have palliative care. 40% of the patients of the 23,000 didn't have palliative care, so 60% had palliative care involved. Now what they found was that those that had palliative care involved in days 0 to 30 after diagnosis, they died faster. They died faster than those that didn't have palliative care, but that doesn't surprise me at all, because when Jeff or Tom or Jimmy call me and say, Carl, this patient's really sick, I need you to see them now. That's not a good thing for them to be saying to me. That means that person is much sicker than those that most of the patients they're seeing. So compared to the rest of the population, those patients died sooner. But what's really impressive is for those that we saw days 31 to day 365 after diagnosis, their hazard ratio was about half of those that didn't receive palliative care. So they had a much more significant survival. Those after 365, they didn't see a significant difference. Their theory was that those patients might be a little bit different. Their cancer might just be responding a little bit differently. But regardless, this was really key to see this. And for those of you that were interested, you have hazard ratios here for the different number of days. But what I really wanted to focus on was this group here that had an overall hazard ratio of about, I think it was about 0.57. So living longer. So Dr. Temmel does an editorial on this paper, and she says, we don't need to focus on how long people live. Please stop focusing on that. What she thinks we should be doing is that we should be focusing on how we're helping people live as well as possible, as long as possible. And she's concerned that if we keep focusing on survival, that it's going to distract us from the purpose of palliative care, which is helping to improve quality of life, and that also supporting the loved ones of the patients. Again, she said over 40% still didn't receive palliative care. Now this study ended technically in, I think, 2013, but this was before the era of the new targeted therapies, and those are really changing prognosis and possibly symptom burden. A lot of the patients that we're taking care of now don't have as many symptoms as the ones from 10 years ago. But I would argue, and some of my colleagues would say, it definitely doesn't hurt to help people live longer. And I'm really happy to be part of that result. And I think it does help with the stigma that palliative care is a last-ditch effort, or end of life, or just hospice. So how do we do it? How do we help people live longer? Well, most importantly, it's from collaborating with the oncologist. Doing strong work, strong communication, seeing people side by side with the oncologist, that's the number one reason. We have to work together to help people live longer. But there's some other ways too. So symptom management is probably one of the most important things that I do. It's not surprising if I help people have less pain, help them with their sleep, help them have less shortness of breath, help them eat better, maybe improve their energy, but that's a tough one. Help them with depression and anxiety. That having this better symptom control, it's probably not surprising that can help you live longer. If I can help you sleep better and eat better, you're probably going to live longer. And better symptom control does a lot of things. It actually leads to better quality of life, fewer ED admissions, emergency department visits, fewer readmissions to the hospital. The main drivers in the literature for readmissions are symptoms and poor communication, and less caregiver stress. And that's a big one because caregiver stress actually increases, having a really stressful caregiver situation actually increases your likelihood of death. So that's how significant it is to be stressed out as a caregiver. So what's left in our toolbox? So we do symptom control. What is it? Just this thing called advanced care planning? Or goals of care? Is that all that we're doing? Well, Dr. Temple and her colleagues, they also looked carefully at what our visits look like over time as we get to know patients. So this is visit 1, 2, 3, and then going on to the last visits and getting to know people in lung cancer. What they found is that initially we're focusing a lot on building rapport, getting to know the patient or their family member. We're always helping with symptoms. Symptoms is really important. Something else that we're helping with is coping skills, and I'll talk more about that later. We actually help a lot with teaching about what the illness is all about. And then as time goes on, things become much more important. Our advanced care planning, helping with decisions about what treatments to do and where they're going to spend their time. So we really begin in the world of palliative care by exploring and helping with something called prognostic awareness, which I'll talk more about in a few minutes. But the goal of any serious illness conversation is really more than just goals of care. We're trying to have an adaptive transformation happen. So if I can help with an understanding about what a prognosis means, I can actually change somebody's perspective. That in turn can change one's goals and can help make their values more clear. My mom actually said to me in a conversation I had with her about her Alzheimer's that she said if I knew how much time I had on earth, I might change the way I live my life. So I can actually help change the priorities of the patient, the family, and sometimes even the doctor. And that can lead to higher quality medical decision making during advanced care planning. And all the while I'm trying to actually help with coping mechanisms too. And provide symptom control because this actually allows for more emotional and cognitive bandwidth. If you're sleeping better and eating better, you got more energy to think and feel and take part in better conversations. So how do we do coping? Well, this is an entire lecture in itself, but what I'll say about coping mechanisms is that distraction is actually really helpful. Now, if you're only using distraction, that's not good. You shouldn't just distract yourself with Candy Crush. But sometimes Candy Crush is really helpful. You actually can. There's no study, but I think it can actually help a little bit with pain. Behavioral problem solving. We might help somebody figure out how they're going to accomplish something really important to them. Emotionally, we want people to feel symptoms. We want them to cry a little every once in a while, but we also want them to be happy too. We got to help some people be happy. Existentially, one of the things that we really help is exploring life review and exploring how spirituality is important to that person.
And one thing that we don't do enough, I know that these guys do, but sometimes a lot of us need to work on just celebrating good news. When a tumor shrinks, I want to be there to help with how important that is. Sometimes I find patients are scared to celebrate. But this is important. We need to celebrate this news. So that's actually a coping mechanism. So as I said, a little bit back to prognostic awareness. So it's defined as the patient's capacity to integrate the likely disease trajectory and prognosis. And patients who have a deeper prognostic awareness can actually weigh the burdens and benefits of treatment and have more meaningful discussions of their goals and values, and actually match their treatment decisions to their goals and values. So I'm assessing it throughout the time that I know patients with a few questions. What's your understanding of your illness? Looking to the future, what are your hopes for your health? And would it be helpful to think about the what-ifs, the potential of not getting better or getting worse? And what are your hopes and worries, and what thoughts keep you up at night? I know this is a busy slide, but this is an important one. So this pendulum here, this is what they call the Pendulum of Understanding. And it's actually, what this says here are hopes more likely to be realized and hopes that are unlikely to be realized. So it's actually very natural for patients to swing between hopes that are unlikely to be realized and hopes that are likely to be realized, or unrealistic and realistic hopes. And this was described as what's called the middle space of knowing by Dr. Weissman in the 1970s. He said it's impossible to live with the awareness of one's mortality every minute of the day. It's just not possible. And it's normal and healthy to have times when the patient almost forgets. And that really makes it hard for us, because if somebody starts talking to me about how they're going to go snowboarding a year from now with their college buddies, then I might worry, well, are they in denial? So having these hopes that are unlikely to be realized, we sometimes think this person's in denial, but it's probably not. It's probably very natural for them to feel that way. You know, if somebody is always staying that way, then I need to really work with them on that. It's also critical to understand in this pendulum of understanding that patients integrate different things at different times from different clinicians, because they're hearing a lot of tough information every day. And patients tell us different things, tell different people different things at different times. So the messages are often varied from visit to visit. So in Palliative, we try to help maintain optimistic hopes by hoping for the best. And then we also try to start preparing for the worst by acknowledging the possibility of dying. And this is referred to as the dual framework. So if you discuss with the patient what living well is and how they value that, they can actually start acknowledging dying by recognizing the difference between living and just existing with an illness. When you're getting really, really sick and you can barely do anything, it's not the same as living anymore. And over time, you can actually start to appreciate both of them at the same time together. So an example I'll give is, right now it's October. Let's say I meet somebody who's really starting to get weaker. And they say to me, I want to go to the beach next summer with my family. Well, what I'll try to say is, tell me more about what's important to you about that trip in the summer. Can we think about what's important to you about that trip and doing it now, or doing it this Christmas? What do you hope achieved with that trip? Are there things that you need to say to your family? Are there pictures and videos that you want to take with your family? Let's do it sooner instead of doing it this summer. So it's talking about living, it's talking about what's important, but it's also talking about the acknowledging that things are not going that well. So with the dual framework, you can have more bandwidth to process cognitive thoughts and emotions at the same time, because you need both to have critical decision making. Thinking enables us to understand and weigh options, and feeling helps us choose between those options by enabling our values. So there's different skills that I use depending on how the patient's doing. There's skills for well times, there's skills for when the patient's not doing well, and then there's anytime skills. What I hope to do is try to create a safe haven for discussing and processing hopes and worries. Sometimes during the well visits, it'd be nice just to say, hey, you're doing great. I love that you're doing great. I'll see you in a month. But I have to take those opportunities to explore a little bit. So what I might do is talk about talking about it. What I mean by that is, maybe I'll say, can you imagine about the possibility of getting worse? Is that something that you'd even like to talk about? Are you okay with talking with me about that? Then there's also the box. And what I mean by that is I actually ask patients to imagine a box in their house where they're putting tough things that they'd rather not think about. Things like the possibility of dying, or things like what they've experienced before with other family or friends that were really sick and died. And what I ask them to do is that sometimes we have to open that box and think about those things, but I also want them to close it and put it away. I don't want them to dwell on those things all the time. Because again, it's not possible to dwell on those things all the time. And then finally, I just ask them to imagine a poorer state of health and what that means to them and what they're willing to live with and what they're not willing to live with. When they're not doing so well, what I might do is name the dilemma. And what I mean by that is you have somebody sitting there in the room with you who really wants to remain optimistic, but I see them getting weaker. So I might just say, you know, I just want to put it out there. You're somebody who's always been really hopeful, and I really love that about you. I love that you're so hopeful. I also see right now that you're getting weaker. Have you noticed that? Are you worried about that? Can we talk about that? And then making a recommendation. What I mean by that is that when patients aren't doing well, they really are looking to us to make a professional recommendation. And during tough discussions, about half of us just say you can do this or that. So it takes time to really be able to say, this is what I think you should do because this is what you told me is important to you. That's why we got to understand what their values are. Then the anytime skills, hope and worry, I've already alluded to it, but I really hope that you can go on that trip next summer. And I'm also worried that you might not be able to. Maybe we can think about doing that trip this winter instead. Ask till ask. What I mean by that is, if somebody says to me, Doc, how much time do I have? I should not jump on that and say, I'm concerned that you might only have 6 months to live. What I should do is say, tell me more about why you're asking me that today. Because there's a lot for me to learn about why that person's asking me. Maybe his wife is concerned. Maybe he's really concerned. Maybe there's financial reasons. But there's a lot that I can find out to really drive what I'm about to tell them. So some of my colleagues and some of you might think, well, if you talk with people about these difficult things, are you going to destroy their hope? Well, I would argue that there are many kinds of hope. You can have hope for having as good a day as possible until the end. You can hope for just simply having a good day tomorrow. You can hope to take part in the dying role. I don't know if that's how many people would put it, but passing along wisdom and saying what needs to be said to loved ones, doing the things that they want to accomplish that they haven't accomplished yet, and even legacy planning. I would also argue that I'm not strong enough to take away hope from anyone, and I stand by that statement. I want you to know that we are actually involved in a really important study with Dr. Temmel. We're one of 20 sites. UNC is also one of the other sites in North Carolina. And it's a telehealth project where we're seeing if telehealth palliative care is as good as the early in-person palliative care. This is important because we know there's not going to be enough of me ever. So right now there's one of me for every 20,000 sick people. So the idea of telehealth is hopefully we can reach more people that we would never be able to get to. And you know, for those of you who had any cancer center experience, it's really tiring to be in the cancer center for half of the day. And a lot of these patients are there for 4 to 6 hours. So if I can talk to them at their home, could that be just as good as me seeing them in person? And that's what we hope we'll find. So in summary, palliative care should be viewed as a complementary rather than competing approach to disease-modifying therapy for patients with advanced cancer. And we collaborate with oncologists to help patients live longer with symptom control, coping, and prognostic awareness, which leads to high-quality advanced care planning and prudent treatments at the end of life. Thank you. Questions now or later?
Questions?